Assalamu alaikum. I welcome you all in this lecture. Today we are going to learn how we deal health insurance under the umbrella of epidemiology. Before I begin my talk, I would like you to understand two core elements. The first foremost would be the process versus outcome. So by the process I mean in certain areas of research work we collect the data, and now collection of the data, for example, if we are collecting the data of blood pressure in a hospital settings, we are just recording certain numerical numbers. Now this numerical number information may have been a valued thing for any company, but we have to define what is the normal versus diseased individual. So the outcome value would be defined, but over a span of time these values may vary. For example, right now the blood pressure referred for a normal individual UAD range from 120 by 80 value, and over the course of a high risk individual having a chances of stroke or cardiovascular issues, we have to deal with these numbers in a different way. Okay, so the process and the outcome are the two core elements we have to take in account as an epidemiologist right at start. Now, there are three terms we need to learn. The first one is efficacy, followed by effectiveness and efficiency. You can read these definitions by yourself, but let me give you a case scenario. Efficiency is in which the work is done under ideal lab conditions. So if I developed like a test for COVID detection, and in my lab settings I am able to identify the individuals who actually have the virus, that is the efficacy of my test. Now, in real life situation, the conditions are not very ideal. There may be mixed infections, or the person may be suffering from some other ailments, or there could be a challenge of immune response or the ongoing drug interference. So such kind of things are working under the umbrella of effectiveness. So my test is efficacy is though 100% in lab settings. What is the effectiveness in actual field conditions? The third term is efficiency. Now, my SARS-CoV-2 detection kit, whether it has some cost-benefit ratio or not. Now, when I coin the term cost, it doesn't mean the simple money matters I am talking about. I am also focused on pain, absenteeism, disability, or any social stigmas associated with my test in question. So these are the three core elements you should learn: efficacy, effectiveness, and efficiency. Efficacy, lab settings. Effectiveness, on ground or on field settings. How good the test performs. And efficiency at the end means whether the test in question is of some value on the basis of cost and benefit, if it is dependent on an expensive instrument, or it is inducing a further disability. Would it be worthy for the patients to go for an extensive screening, or should we drop the option? So now, in any journey, we start from the process and ends on the outcome. Now, outcome means if we define an outcome in terms of the detection of virus, that's the one outcome that we want to diagnose which one of SARS-CoV-2 individuals are positive. So we identify these patients. This is one way of outcome. Now first it should be quantifiable, whether we just need a quantification of presence or absence, or we want to understand the load of virus. Secondly, it should be relatively easy to define and diagnose. So for example, if I'm talking about SARS-CoV-2, I would be focused on the presence or absence. If it is present, irrespective, then how much value it is in terms of whether the copy number is 10,000 per ml or it's 20 lakhs per ml, then I declare this patient to be positive or this one as a carrier. This should be defined right at the start of the study. Thirdly, it should be set as a standard. Pardon me. So it should be set as a standardization for study purposes, that whatever we are doing, it should be uniform. Like if somebody is working on SARS-CoV-2 detection, we should be relying on the virus detection, or we are just understanding the immune response genes. For example, if I am asking for immunoglobulins high or a lower uptake, or the leukocyte count, and I attribute that phenomena with the SARS-CoV-2 presence. Now there are many multiple issues. For example, in bacterial infections, immunoglobulins levels may vary. So as an individual, it will be very difficult for anyone to check whether the person is actually suffering from COVID or something else is responsible for the low counts of leukocytes or immunoglobulins. Now, the examples of outcome in a vaccine plan could be the number of individuals, how many individuals are immunized, and who the individuals who are immunized, whether they are at risk, high risk, like the old age individuals, or the ones who are immunized show any serological response. So, number of individuals are exposed at any clinical disease. Now, all these parameters are actually a variable, but they should be defined right at the start, that what would be the outcome and how would we decide that this is the objective. Suppose everyone in this room or in this class is willing to attend the lecture, but at what point they want to, whether they are present over here just for attendance or just to learn something out of it. Now this objective is the intent which is being set by the students right at the start. Now my intention would be that I count the number of students at the end of the lecture, that how many were actually staying in the class. This is the one outcome I defined right at the beginning of my lecture. So these are the points which we make in line. Now, the classic epidemiological model and health services model relies on two factors. Number one, environment factor, followed by the healthcare facility. Now, these are actually defining the health outcome, and then we are further intrigued by the information. Now, we literally, in case of health insurance, need large data sets. Why we need a large data set? Because we want to assess the efficacy, efficiency, and not efficacy, efficiency, and in a larger prospect. And this efficiency and effectiveness are very much indeed required. Let me quote an example. For example, if a company is willing to, like, for example, health insurance company is desiring an intent to insure an employees of this organization. Now, if they are willing to pay an insurance cover for all of us, or all the students participants in this class, on what grounds and how much cover they would like to bear. So let's say every student in this university is having an insurance, health insurance covered. Now from health insurance prospect, they want to know at what age group they are more prone to what kind of diseases. If they are prone to any chances of paralysis, cardiovascular issues, this data is required. Now this requirement of data is being fulfilled by epidemiologists. Now this means that there is a randomized set of trials we are going to set in for the eligible population. Now the randomized assignment has its own challenges. For example, if in USA Medicare is the main insurance company which is responsible for covering old age patients, and the data is originated from them. Now what they are trying to do, they are trying to cover the health insurance for the old age individuals, and they want to study whether this kind of cover has any improvement on the overall health well-being of those individuals or not. So such kind of approaches are also, what you can say, questionable in certain terms, in terms of ethical issues, in terms of the selection criteria, that we are asking someone in Care 1 to avail a facility of healthcare, and we are abstaining a certain bunch of peoples not to avail that facility. Okay, so for example, a healthcare facility may first let me quote an example. For example, in stroke patients, over here there is a schematic layout plan of clinically affected individuals. Now these individuals, which you are looking at the number of 457, were randomly assigned into three categories. Let me name them as A, B, and C. Starting from 152 is A category. Now, in this category, all these individuals who suffered from stroke, they were kept in a hospital under observation by a doctor who was specialist in stroke management. In the B facility of 153 individuals, these individuals were retained in the stroke unit, but they were kept with the counseling of multiple doctors' views. The third one, 152 in stroke, and this is the right on my right side over here, 150 confirmed stroke cases. In this box, what we observed or treated these individuals for a home care. So these individuals were advised to go back to home. Now, what the intent of PI was to assess which approach is the most effective one. Should we keep these patients in hospital or should we send them home? So over a span of time, they learn that the individuals look at the right side survival plot, Kaplan-Meier survival plot. So in this plot, you learn that the stroke unit individuals who were retained in the stroke unit have a longer life expectancy as compared to the individuals who were left out, or they were at the disposal of domiciliary measurements. So they were basically a home care facility. So these kinds of randomized trials were used to assess what kind of approach is most effective and whether the insurance company should pay for such a long duration or how much they should pay. Now, why we opt alternate to randomization? Because randomization is logistically complex and extremely expensive. Secondly, ethical problems. So the individuals who stayed home, they were also suffering from the same disease. So whether it should be ethically correct to retain them for to or direct them under their poor debilitating health conditions. Thirdly, the randomized trials often take a long time to complete. So these are the three core elements. So before and after the design of a historical control. So the alternate to randomization is that, let's say, in Pakistan and Afghanistan there is an ongoing campaign or a program for polio vaccines. Polio drops were being advised to the kids. Now, before the start of the program, what was the percentage prevalence of polio virus, and followed by after the implementation of the program. Now in this case, the randomization aspect is being divided on the basis of program before the program, how much disease was prevalent, and after the implementation of a program, how much we can dealt with that challenge. All right. So this is an alternate approach and it is being used. Now over here the examples which are being put forward for your attention was the prospective patient care system in USA for congestive heart failure, myocardial infarction, pneumonia, and hip injury and head injury. So in this aspect, from the prospect patient care system in USA, they are not inducing hip fractures to the individuals and under observation that let's study their hip fracture, but they are monitoring them that before the fracture what was their quality of life, how much actively they can walk, and after the hip fractures what is their tendency of recovery, so that we can judge how long this patient is going to stay and how long it could be dealt under a health insurance or it could be dealt with the system. Okay, so this is how where the epidemiology scopes rests. Thank you so much for your valued time and attention. I know you must have lots of questions. Please feel free to ask or write me. Thank you.